So thank you for joining us this morning. It gives me great pleasure to introduce our speaker for this morning, our newest addition to the GNI family, Dr. Tyler Scullen, who joined us as a comprehensive vascular neurosurgeon. Dr. Scullen grew up in Massachusetts, where he went to college and majored in neurobiology and chemistry. He got interested in the biomedical sciences, but then led him to work in a research lab at the Massachusetts General Hospital, in collaboration with labs in Dana-Farber Cancer Institute, MIT Broad Institute, and the Harvard Stem Cell Institute. From there on, he wanted to go into medical school, and then was accepted to Tulane University in New Orleans. Throughout his medical school years, he became increasingly interested in neurosciences. He applied and was accepted for a fully funded fellowship at the NIH. He was awarded the DeBakey Scholarship at Tulane for his research efforts as well. He did his residency in Tulane, where he also did an enfolded fellowship in cerebral vascular disease, both endovascular and open vascular. From there on out, he went to Buffalo, where he did a full endovascular and open vascular fellowship. He joins us today to talk about the new frontiers of cerebral vascular neurosurgery. Dr. Scullen, the floor is yours.
Thanks, Dr. Rami. Let me just share this guy. Everyone able to see that?
Yes.
Okay, thank you. So what I wanted to talk about a little bit today is, avenues for neuroendovascular surgery that, treat diseases that are not traditionally either managed by endovascular or managed by neurosurgery at all. The majority of the techniques I'm going to talk about today are things I've been exposed to during my fellowship, and it's important to know that these are in their first stages of evolution. They're very resource intensive, require a lot of moving parts, but as we've seen with neuroendovascular surgery, everything over time rapidly optimizes and advances into better devices, better technology, more efficient, using less stuff to achieve more. The concepts I really want to capture are really that these diseases can be treated through minimally invasive means, and although we're still in early stages and the data is quite frankly limited, and the current techniques we have in some cases some unacceptable risk profiles, it's just sort of important to think about how we can move forward in bringing these things under an endovascular umbrella, because a lot of times these routes actually seem very promising and ultimately allowing for quick low risk care. So I don't have any disclosures. So as Rudy mentioned, I went to residency at Tulane. It's a 50-50 split with Tulane and Offshore Medical Center, which is another big institution there, and I received mentorship at both locations. And then I did my fellowship in Buffalo before coming here. So just a couple of things I'm going to go through, and there are plenty more things that I can discuss too. It's just I'm trying to keep it a rather shorter list. So starting with arterial embolizations. So AVM embolization isn't super novel, but it is something that's relatively recent. Traditionally managed via open techniques, this pathology can be treated endovascular in two different ways. One of them is that you basically try to prune arterial feeders to reduce volume and flow to the point where you can either treat it with radiosurgery, or if it's a straightforward surgical approach, treat it with surgery. This is obviously reserved for things that aren't right on the surface, easy to grab at the time, because you can just do that surgically. But with time, we may find that we can achieve embolization cures through transarterial routes or get very close to it. The big one I'm going to talk about is actually trying to go for cure off the bat with very selected AVMs, ones that are generally inoperable, ones that are small compact nidus that have bleeds in their history and are in deep locations like basal ganglia and such. So this is just kind of going over what we all know of what AVMs look like and what their kind of components are, what the options are for treating them, and just kind of the idea of the structure of it. So the data, the biggest data thing we have is from this Aruba trial, which I'm not going to go into all the criticism for it, but basically it really is sort of a disservice, in my opinion, to AVM treatments based on just how the study was structured. But what I want to kind of get into is, um, how patient selection can improve outcomes in AVM treatment, and also, which AVMs are really amenable to taking this approach. This AVM score from Buffalo, it's been externally validated in terms of complications, but to be honest, it's really hard to follow um, outcomes in AVMs from endovascular, just in terms of follow-up, and in a lot of the series that go back and forth when you're coming to stage embolizations aren't great in a lot of places. And a lot of conclusions come to that, like, they should be treated at centers of excellence and so on. But I think what it really comes down to is just selecting the right patients. So when considering this, you need to think about what it is you're trying to accomplish, as with any pathology, obviously. In AVM embolizations, the two rules for it, I think, are: one, if you have larger, grade 5 big AVMs, you're really trying to prune down for a staged procedure, or AVMs in patients who, won't necessarily do well with an open procedure that's long with a heavy lot of blood loss, and you want to reduce volume and flow so that you can either do radiosurgery or resect it. And this is for transarterial embolization. And this is kind of going through that. The one I want to kind of focus on, though, is doing transvenous and transarterial treatments for cure, which um, I believe is a very impactful way to offer a treatment to people who otherwise are with disease that's untreatable. So, some of these AVMs appear in young patients, bleed multiple times, or in areas that, have just absolutely unacceptable, surgical morbidity in terms of where they are. Good examples are ones that are in the, ventral basal ganglia that receive a lot of hair-like or lenticular striate feeders in some parts of the thalamus, or you could even argue in like deep areas towards the motor cortex. So the concept of doing cures through transarterial transvenous treatments are that you want to basically try to retrograde fill it with some kind of emboli. This can be done by one, on the transarterial side, blocking off major feeders feeding the nidus, which means that these AVMs really need to have, either one or two big ones, or, like I mentioned with lenticular striates, a bunch of small feeders that are coming off of a pretty localized location. The ways you can do this is that you can get into the transarterial axis, and you can either balloon occlude or liquid embolize, bigger feeders, or you can just put balloons in major vessels like ICA and ACA to block off lenticular striates. Simultaneously, you come in through the major draining vein from the venous side, and when you're ready to do this embolization, what you're going to do is basically plug off the outflow zone at right around the exact same time that you plug off the inflow zone. And then once that's done, you're going to reverse pressure cook, so to speak, and fill it with liquid embolate from the venous to arterial side. One thing about doing this, because obviously when you're blocking off venous drainage, and even if you have closed off the majority of arterial feeders, you're still going to have some feeders that you can't see angiographically, or are just too small to kind of get at. And so, obviously the giant danger in AVM surgery in general is that when you block off the draining vein before all the feeders are gone, you're going to have a rise in intranidal pressure and rupture. So to supplement this, you have to have some way of really dropping the patient's blood pressure. The way I've been exposed to is through rapid ventricular pacing, which I'll talk about as well. But this is just kind of going through this. The idea being that you need 3 axes for this. So you basically need a venous sheath to come up the venous side. You need an arterial sheath to come up the arterial side. As it stands now, and again, all these things are, I suspect, subject to a lot of optimization as we go forward in the future. You really need 2 people for this, because you are going to block off arterial, block off venous almost simultaneously. And at the same time, you're going to pace. And to pace, you're going to use another venous sheath. So you're talking 3 sheaths in total. And that's other venous sheath is just to float a pacing catheter into the right atrium, which is very straightforward. There's these small 6 French balloon catheters that you just kind of dump in there. And then adjusting the pacer is actually not very complicated as well. What you essentially do is you float the thing in there. It has like 2 controls on it. It has one for current, it has one for voltage, and you're basically going to decrease the current until you see a normal heart rate, and then you increase it until you see what's called capture, which means that you're seeing the pacing working on the EKG. Once you get there, you're going to pace at 180 beats per minute, which should drop the maps to 20 to 30. And you do that in 15-second intervals, and these patients do well. It's a cardiac technique that I think is transapplicable to neuroendovascular. It just requires some modification, sort of like the birth of the whole field. So as I mentioned, when you set these things up, you're going to get 3-access, and you basically just want to find a way to block off both the front and the back as you're decreasing nidal flow pressure. The way I've seen it done is that when you're blocking the arterial, as I mentioned, you use onyx or a balloon, and then on the venous side, what I've been exposed to, it requires a lot of embolization material, which I'm not sure is super necessary. But what you do is you drop NBCA to immediately occlude the vein. You follow that up with a coil, and then onyx 34. You do this with 2 microcatheters on the venous side, one that drops all those things that are blocking the backside, and then you have another one that's basically sitting in the nidus itself, more between where you're blocking the vein, between where you're blocking the artery, usually using a detachable catheter like an Apollo. And then from there, you just start pushing onyx, and it will, with the nidus having decreased flow, and then the arteries and veins being down, you can actually very nicely fill the entirety of the nidus in all its feeders with minimal involvement, if any, with en passant vessels. This requires a small compact nidus. Obviously, once it gets larger, then you're in a real danger that you're gonna partially treat the AVM, which stats have shown has devastating effects in terms of re-rupture rates. So this is just kind of going through how to set up the pacing, and I'll have a couple videos here as well. So this is one case I did with one of my staff there.
In this video, we illustrate transvenous embolization of a left basal ganglia AVM with a transarterial balloon assist and cardiopulmonary arrest. Patient is a sexagenarian male found to have a left ventral basal ganglia AVM on work above an ICH and referred to our clinic. Major arterial output was noted from the medial and lateral lenticular striate groups of the A1 and M1 and the carotid terminus, including the recurrent artery. Major drainage was into the deep system. A 3-axis system was utilized, the goal being to achieve proximal balloon occlusion to perfect reflux into the anterior circulation, transvenous coil and liquid embolization for outflow occlusion, and a final transvenous liquid embolization with onyx 34 from a detachable microcatheter. During embolizations, cardiac standstill was achieved using rapid ventricular pacing to 180 BPM in 15-second intervals. To begin, the arterial and venous guide systems were positioned to control angiography and venography obtained. The transvenous headway and Apollo microcatheters were then delivered across the basal vein and positioned in a staggered formation within the nidal outflow zone, and positioning was confirmed with microinjections following the placement of the second microcatheter, which was the Apollo. Via a transfemoral approach, the pacing catheter was then advanced into the apex of the right ventricle and thresholds adjusted for future pacing. The Cerebral balloon microcatheter was then positioned across the A1 segment, protecting the lenticular striates and the artery of Huebner, and the eclipse across the terminus and M1, protecting the lateral groups. Together, these balloon microcatheters, along with transventricular pacing, allow for total flow arrest during transvenous embolization. Intermittent rapid ventricular pacing was initiated, and the balloon catheters were inflated to occlude and protect the anterior circulation and achieve intranidal flow arrest. Staged outflow occlusion was then accomplished using first transvenous coil embolization from the headway microcatheter, which was followed with liquid embolization with NBCA to plug the coil mass, thereby jailing the detachable Apollo microcatheter tip between the now plugged inflow and outflow zones. Transvenous liquid embolization was then completed using Onyx 34 via the strapped Apollo, and following complete embolization, the tip was attached and all microcatheters removed, with final angiography demonstrating total embolization of this otherwise inoperable ventral basal ganglia AVM and preservation of the anterior circulation and deep venous systems. Postoperative imaging was within normal limits, and the patient was neurologically intact on postoperative exam. Thank you. In this video, we'll
Oops, sorry.
In this video, we illustrate.
I have another one there, but I won't, in the interest of time, I'll just move along. But what I basically want to highlight is that, there are a subset of patients who have AVMs, and, they're often young, that are essentially inoperable and are rupturing, and, and even in a rupture cause, symptoms through steel phenomenon and things such as this. And there's really no surgical option to treat them. A lot of times, radiosurgery can be very difficult in those locations. And, you can really, this offers a treatment option that can be very effective if the patient's selected correctly. Again, it's very resource intensive, requires a lot of catheters, requires a lot of money and all these other things, but this is something that, not necessarily is in its most optimal format. And, with time, as with the device technologies, we should be able to reduce some of these redundancies to make it a more, a more realistic procedure to perform in many centers. So the next one I'm going to start talking about is chronic total carotid occlusions. We all know about steno-occlusive carotid disease, very significant source of morbidity, and a major etiology of stroke by the TOAST criteria. Symptomatic disease in general is fairly not straightforward, but we have a general idea of like paradigms for treating it. You have the stenting, the TCAR, the CEA, based on what the anatomy looks like, what the patient's functional cardiovascular status is, and so on. But there becomes a question when you have patients who have total carotid occlusions. So these come in two forms. They're the ones who are subacutely occluded and the ones who are chronically occluded. There's been a series of trials that have failed to show that revascularization for the patients who need it is super effective. But again, it's one of those things where when you're talking about general statistics and including the entire population, it's important to look at subsets of it. So, patients who have flow asymmetries and volume asymmetries or are symptomatic, on the side contralateral to, or on the ipsilateral to the occlusion, and also who have retrograde filling through the vessels that they are filling on that side, they're the ones who have had more success when you're considering for bypass. And this can both be patients who have acute volume deficits, that where you have maximum vasodilation on one side where the brain's screaming, or a direct bypass can give them immediate reperfusion, or ECI or EDAS and similar indirect techniques where you can perfuse over time, which is shown to be effective in select cases. The studies that can kind of determine to help figure out which patients would benefit from revascularization at all are things that we know, like CTP diamox, which can show you the vasodilation state of patients. Obviously, one issue with CTP diamox is that if you have patients who are fluctuating in terms of their symptoms, or really are at a point where they really critically need blood and their hemodynamics are very tenuous, and you really can't be stressed, a diamox can actually cause strokes by doing that. A much less invasive way is by using TCD, breath holding indices, which is basically just doing a TCD in the MCA, recording the velocities, and then having the patient hold their breath for 20 to 30 seconds. And then there's a calculation you can do to see how much it deviates from baseline. It kind of reflects the vasodilation status. So obviously ECIC is something that's been explored a few times, but you gotta wonder if you can do it open surgically. Can you do it endovascularly? So the scare with, trying to revascularize a chronic total occlusion through endovascular means, obviously, is that you're basically going blind. So if you come up to a vessel that's completely blocked off and are trying to get through it, you could very easily dissect, and you don't know if you're in true lumen or not. And that's still the case, with so there are two ways to kind of go about this. One is just trying to drill through clot and hoping you're there, which you may or may not be. You really have no way of knowing. Or doing a subintimal dissection and traveling in a dissection plane up to an area where the lumen is to be open, and actually punching back in, and then just plasting the whole thing and stenting it along the line. Again, limited data on these things, very intensive in terms of what you got to use, but something that is just offering a glimmer of something that could potentially be amenable to minimally invasive treatments, where you're not having to feed scalp arteries into the brain in a more morbid approach. The patients who work best for this in the limited experience that we have are ones where you can see filling retrograde distal to the occlusion down to the extradural carotid, so in the cavernous or petrous segments. And that is essentially because if you're traveling through a dissection plane and you don't know really where you are until you reach an area where you see blood filling retrograde into true lumen, and you could dissect into the subarachnoid space if it's in the dura, which is totally unacceptable for risk profile. However, if it is extradural, you can safely get back in there, especially if it's along the petrous area. Patients who are, selected in certain areas that have this, area that you can go after are actually do well. From limited small case series experience. And there's plenty of case series that say the opposite too, by the way. There's lots that say that they re-occlude quickly, which makes sense because you're putting in these big long stent constructs. It really comes down to being able to find a way to make this optimized where the patients that work, we can, decide, it worked for this reason with these factors, and these are the ones that we can hope to figure out how do we apply this to other patients and what we modify it. And, I think a lot of, predictive statistics will come into a role with that as more and more data is accrued, similar to what they did, basically how MD Anderson got started, where they started using that for cancer protocols. The same concept can be applied. You can figure out what works with what people find, where the correlations are, and find ways to make this work for everyone, and find ways to do it easier than, sending up a million different balloons. So what you do with these cases is you first try to get through the occlusion proximally. You're either going to see one of three things if we're doing total occlusion. One is that you're going to have a microchannel that you can actually catheterize with a number of different wires that you can get through it without having to go outside of lumen at all. Another is that you're going to see a tapered tip of the occlusion, which kind of offers you a good avenue into where, it gives you some degree of confidence as to, you're probably going through occluded true lumen, but again, not certain, but it does give you it does make it more likely that you're going to have a less intensive procedure. The ones that are tough are the ones where you do the subintimal dissection, and it's not tough to get the wire up along the dissected area. It's the tough part is really getting back into the lumen once you're past the occlusion. That can be tough to do even with very stiff wires. And there are devices that they make to do this. Almost all these things are borrowed from coronary techniques. For example, there's this thing called the Stingray, which is basically a balloon that pushes the orientation of the microcatheter tip towards a true lumen that allows you to punch in. But in general, it's best to try to not dissect if you can help it, just because it's much harder to get back in distal to the occlusion. But both procedure techniques work equally well. It's just, one's a little bit more difficult than the other, technically. So you're going to try to catheterize the lumen. Once you get a wire across into true lumen from whatever means, you're going to pass a microcatheter up, do an injection, and from there you can place a support wire. Anything that's a big stiff wire. We used a lot of the Spartacore 014-300 length, which is it's basically like the same stiffness as a NAV6 wire. And then from there you can pass up a series of balloons, recanalize it, interrograde or retrograde, and start stenting. The petrous segments or cavernous segments are what the most success was kind of found was using coronary balloon mounted stents such as Onyx Frontier, and then bringing that down to the petrous segment, after which you want to put like a closed cell stent, like a wall stent. You want to have that overlapping on the inside, so everything's kind of pushing out to prevent any malapposition in the wall that would increase the risk of stenosis or reocclusion, particularly at the cervical petrous junction. So these patients, even when you recanalize them, you got to watch out not just for reocclusions, but also for hyperperfusion injuries. These patients have brains that are screaming for blood. So, in the same principles obviously apply to near total occlusions. Whenever you're have a huge restriction in the brain is just trying to draw it all in, and then you'll suddenly open up this big giant vessel, you got to really monitor the blood pressure after that. Autoregulation might not be able to catch up with that as rapidly as needed. And you can have real big bleeds from this. And this obviously doesn't just apply to chronic total occlusions. It applies to anything where you have a very severe stenosis for a long-standing period of time. So this is just kind of going through some of the options. So as I mentioned, you kind of evaluate what's going on. We typically used a balloon guide catheter, which, how necessary it is to have a balloon guide. It's more just for anchoring it, just to hold it, to have a good solid support system through which you can push some of these stiffer wires. Flow arrest obviously doesn't really matter here because you're already occluded distally. And in fact, flow actually helps you out a little bit because it kind of guides you through any microchannels you might want to be getting into. So, what wires you would kind of use to do, there's a whole, and again, this is one of those things where right now, we're borrowing coronary wires to try to get through these things. So like, there's a whole bunch of stuff here that probably seems unfamiliar to a lot of people, but this is one of those things that can be, optimized or, you could have just small changes to existing micro wires that we use periodically and can kind of standardize things so that you're not trying to use different little pieces to, do every little thing. However, if you have a microchannel present, finding like, relatively stiff wire like the Spartacore wire or, Fielder wire, which is a coronary wire that's a similar stiffness, you can use to find those microchannels and get they pass a little bit more easily than try saying like a Synchro 2, when you have tortuous little channels there. They give you a little bit more support and then allow you to kind of pass a microcatheter past them. If there's a tapered stunt present, we typically used, these stiffer CTO wires that are used in coronary procedures like Gladius Mongo or Pilot. And then if you have a blunt stunt, a big duty wire is generally necessary to try to, and again, the whole goal of this is to stay in occluded segment of true lumen. But if you do get into the subintimal plane, there are methods to punch back in, but none of these wires will really do that. And the reason is not so much that the wire can't punch back in, is that, it's going to always follow the path of least resistance. So it's just going to glide between the intima and media and just keep going distally if you don't find some way to really be able to orient it and poke it in. So the one way you can do that is, well, here's one that does not involve subintimal dissection. This is a case I did in fellowship. And this one is just, this is just when a true lumen was actually found. So I'll start with this.
In this video, we demonstrate transfemoral recanalization of a chronic cervical petrous total carotid occlusion. Patient is an elderly male arriving as an NIHSS 10 stroke page, was found to have a left chronic appearing total carotid occlusion with decreased CBF and increased TTP on the affected side. MRI shows watershed territory infarcts. DSA confirms a chronic left ICA total occlusion with reconstitution in the distal petrous segment via collaterals. Decision was made for a transfemoral revascularization and cervical petrous stenting. To begin, the lesion was crossed with an 014 wire, and a Navicross support catheter was delivered into the petrous segment, where positioning was confirmed with angiography showing that the catheter was within the patent aspect of the petrous segment. Angioplasty and stenting of the cervical segment was then accomplished using a closed cell carotid wall stent and an aviator balloon. This was done under flow arrest using a walrus balloon guide catheter. A long carotid wall stent was used here, spanning from the common carotid into the distal cervical segment. Following deployment of the stent, the walrus was then deflated and then advanced into the distal aspects of the stent, where attention was turned to the petrous segment. Distal wire access within the petrous segment at the aspect of the vessel that we know to be open was maintained during the entirety of the procedure. Reconstruction and stenting of the occluded petrous segment was then accomplished using a balloon-mounted drug-eluting coronary stent under flow arrest provided by the walrus balloon guide catheter. It should be noted that the walrus in this portion also serves as an angioplasty device within the distal cervical segment just at the cervical petrous junction, following which the walrus was deflated and withdrawn, and a second carotid wall stent was dropped to bridge the petrous and cervical stent constructs. Final angiography shows complete reconstruction of the entirety of the carotid artery from the cervical to the petrous segments and restored flow intracranially. This video illustrates the feasibility of managing chronic total cerebrovascular occlusions with endovascular.
So that's just an example of, that patient did very well. let's go on here. There's another one I want to show you that involves the Stingray device I mentioned. If you go subintimal, this one was a case done by one of my senior fellows at the time, Kunal Ragor. So let me just play this real quick, and this just shows how you kind of can get back in. And see if I can. I thought I had some narration with it, but anyway, it's the same concept. You're basically just trying to get into there. Once you're distal, you're basically just getting was this the one? Was this the right one? Yeah, okay. So yeah, once you're in there, you basically you follow subintimal, you create a new channel by just plasting and stenting. The problem again doesn't become in the proximal aspect, it becomes trying to get back into the lumen. As you can see here, you have a microcatheter that's right next to where the lumen is, and this is where you can use this Stingray device. This thing is meant to go subintimal. You blow up a little balloon, and it orients the microwire so that when you use a stiff microwire, you can actually just punch right through into it. Again, this is something that's not designed for neurovascular, and these are all like first generations. Like you can the technique, the devices, the clinical knowledge we have on it. It's like the first iPhone. They were exciting, but like they had a lot of problems too. And then but now with the successive generations, you see how great these things are. Like I'm talking on a Mac, it was but I remember the iMacs I thought were kind of pieces of crap when they put them in my public school library when I was a kid. So, and then once you're back in, it's the same concept. You're just plastering everything up, and this patient as well did very well. I'll go ahead and move on. Another thing dealing with carotid stenosis is lithotripsy. So, concentric calcified carotid stenosis. When you have patients who have this ring of calcium around it, that traditionally is something that you would treat via a CEA. Because the problem with stenting is that when you have that concentric stenosis is that it's, even if you're able to angioplasty open a small channel like that, it's probably just going to collapse right back on you. And by concentric, I mean, obviously that you don't have any breaks in the calcium as it goes around. However, in patients who can't undergo CEA for, medical conditions or whatever contraindication, and you go and stent with heavy calcified stenosis that has even small breaks in the calcium ring, you see that you can actually effectively angioplasty and stent it, and because there's those breaks that allow those pieces of calcium to kind of move together. So the concept of lithotripsy is something that again is used traditionally in vascular procedures, usually things like subclavian stenosis or in peripheral disease, and it is the idea that you use ultrasound to from a transluminal approach break calcium within the the subintimal areas. And it's been shown to be very effective in peripheral procedures, and so the concept kind of came up, well, can you use this in patients who have concentric carotid stenosis but otherwise are not good candidates for CEA or even TCAR, patients who generally can't tolerate anesthesia. What we found is that lithotripsy, and we published a small series on this, is fairly effective. It's basically just like another angioplasty balloon. It's like a 4x40 like a construct. You just send it through where you would normally put your pre-plasty balloon, inflate it, and then there's a little thing, you just throw a wire off the table and you hook it up, and you just press these buttons, and it does these 10 pulses. It does these 10 pulse rounds, so it'll do like 10 pulses, then it'll stop for like 10 seconds, you can do 10 pulses again, and so on. And it really does melt away the calcium, and I'll show you kind of pictures of that. And so obviously this is a novel technique, so long-term outcomes, remain to be seen. And I'm not going to say the same thing over and over again, but all these things require, optimization essentially and advancement. The problem with these techniques, with lithotripsy in particular, is that one of the major positive predictors of periprocedural mortality and transfemoral carotid stenting in patients with high risk anatomical features, which obviously these would fall into, are that there's a direct correlation between catheter manipulation time and infarct. So, the longer you're in there and doing something, the higher your risk goes. So these procedures are, all, as we all know, in high risk carotids, you want to do it as fast as possible, safely, not rushing through, but just safely and methodically moving quickly and efficiently. The lithotripsy balloon, because it has all those pulses, requires a much longer time for it to actually take effect. So that's a major drawback of it. It's been demonstrated in other studies to show that it does cause these little microfractures. And so it basically turns a concentric calcified stenosis into a fractured, like little plates that can then be easily angioplasty with a bigger balloon if you want to go above a 4. And so this is one of the things we discuss, again, very small series. But these patients do fairly well. So just some examples. And this one, starting with there. I think this is a video, but this is I'm just gonna show you a video kind of showing this rather than go through slides. I got one here. So, this is a patient who had concentric calcified stenosis, by all, the rest of the procedure is essentially just same thing as a normal carotid stent. You just get a distal embolic filter up, if you can get one. Obviously, sometimes if you have very severe stenosis, you might have to, go without it, but you just bring this lithotripsy balloon up, you let it pulse for a while, and it really does melt away the calcium. Once that's in, you can either, angioplasty it up if you feel like you want to get a bigger lumen size, or, you can just drop a stent right behind it. The problem with, just using it as a solo is that, like, if you have a bigger artery, it only does go to a 4. So, you might, often you might want a bigger balloon, but still any flow you can get is good. This is just using the IVUS, which I think is kind of, I don't know, the role for that to me in endovascular. I think it remains to be really seen, but all I'm trying to show is that it works. You can see, the effects of it. It really does open these things up. The other thing is, it is an over-the-wire balloon. So you really do need an exchange length wire, if you want to use a distal embolic filter. And that's because, again, this is something that's not adapted to what neurosurgeons, neurointerventionists do. But you can use a Spartacore if you want distal embolic protection. You can exchange for you can backload a workhorse wire, which is essentially the same thing as the NAV6 wire. It's just longer. It's just almost an exchange length version of it. You can just backload it onto the NAV6 filter. It has a little block at the end that will catch it. Or they can start making a NAV6 with an exchange length. But so there's that. This one is super early in its development, but there's this concept of electrophysiology through endovascular techniques. So brain-computer interface, obviously is a way that you try to, a lot of the development with it's been involved in coding analysis or signal analysis, but you're basically trying to find a way to take the signals that are coming from motor cortex for volitional control and transfer them to some kind of external unit that allows you to manipulate your environment through whatever means. This obviously has tons of interest from government agencies such as DARPA, because you could give an ALS person the ability to use their hand, or your hand could be a machine gun or a fleet of planes or whatever. So this is something that generates interest in a lot of different ways, but it also way for functional neurosurgery to potentially fall under endovascular, and through collaboration with these subdisciplines, you could see how this can give you access to a lot of areas of the brain that are otherwise fairly difficult to access without doing transcortical lead placements or SCEG, which is again, SCEG is also kind of I'm not going to go into it, but that's a huge tool in neurosurgeon's armamentarium for a whole different talk, I guess. But so you can go in and you can manipulate and get data from areas of the brain that otherwise are difficult to access, like using transvenous routes with basically these electrodes placed on stents. And you could imagine in the future too, you could probably do them arterially as well. Obviously a concern would be with strokes, because you're going to have the current designs have like a wire that you float out to an interface device that allows capture to an external system. So this is talking about it for ALS. They have this this switch device that basically allows you to volitionally control a computer interface. And the way this thing is done, this is in very early trials, is in case you're trying to find motor cortex in the superior sagittal sinus. So you float a stent up into the superior sagittal sinus. You're doing this through IJ access. You deploy it. You want a functional MRI at this point that confirms where the motor cortex is, co-localize it so you can with a spin, so you know you're in the right spot. And then you basically just tunnel this thing out of the IJ, and then you go supraclavicular and you put this little thing in. This is very new in its development, and obviously, as it stands now, the cases that they show that are effective are probably very cherry picked and very rare. The one case that was done at Buffalo, the patient had a lot of complications from their wound afterwards in that area. But as with everything with time, this can become a lot more streamlined, effective, and open a lot of possibilities. There are a lot of diseases that are likely both from known functional diseases in terms of neurodegenerative disorders, or as it's becoming increasingly possible, major mood disorders and psychiatric conditions, but also systemic disease that has has a clear neurologic or neurohormonal component, things like obesity or essential hypertension and things like this. A lot of that is mediated through one way or another through deeper brain systems. So the end result of this is there's a huge huge potential area that neurosurgery can go into. You're talking both for applications of helping people with neurodegenerative diseases, applications in terms of just general everyday living with in advances in technology with brain machine interface, which can be both in civilian and military perspectives. You have the ability to treat diseases that otherwise would be right now we basically just treat via symptom management and things like that I'm talking about, or like obesity and hypertension and things like this. And then you have you have the ability to learn a whole lot more about brain biology, which is a science that went forgotten for a good amount of time. When kind of all the moral pitfalls of early psychosurgery came out. But and I'm not condoning anything that any of those things did. Tulane has a very big history with that with Dr. Heath, and some bizarre experiments being done with patients, by placing electrodes and having them do crazy things like forcing homosexual men to have heterosexual sex with prostitutes while they're being recorded and stimulated, which is actually a publication from Tulane. But the data, these guys were operating without any moral conviction, but the data that they're getting is very valid, and it got all thrown away because for obvious reasons people were like, what are you guys doing? Like you got to stop this. This is totally immoral. But unfortunately, no one thought are there other ways we can apply this in the future, until very recently when SEEGs really started making a real comeback. And I think this is something that can be applied to the neuroendovascular realm as well, particularly in the future as things get more advanced and more efficient. As it stands now, all the trials that are doing this, like the command trial and switch study, this is all stuff that's designed to basically demonstrate clinical safety and patient placement. This is an example of a guy with ALS who had this thing in place and can control things like sending emails, searching the internet, turning on lights with his mind. So this is just showing how this device kind of works. Is pretty straightforward. It's just a delivery catheter that you just float up there and deploy, and then you just implant this telemetry unit. The command trials, the one that Buffalo is involved in, as well a few other places. And they have all these occlusion criteria, and right now it's effective for the select patients that they like to show, but in terms of broader, this requires a lot of work, but still a very promising concept. This is just kind of showing that this thing, and it's showing the stent deployment. confirms position, and then you plug it into a telemetry unit, create a pocket, and then turn it on. This is the case that was on a Buffalo, obviously. So as I mentioned, promising field. Endovascular cerebrospinal fluid, CSF diversion. So we put in a lot of shunts. And there's an endovascular option. Again, in its first stage, it's a real pain in the ass to put in. It requires a lot of stuff. And its effectiveness remains to be demonstrated. It's really only, I mean, it's not on, it's all in trial phase in the United States through the Ceravas trial. And then, it's being used a lot in places like Buenos Aires, where they have like larger case series where they're able to kind of operate with impunity. But what this is, it's a fixed pressure valve that you're basically trying to punch through, and it's being used predominantly in trials in the United States, being used for normal pressure hydrocephalus, and in Argentina they've expanded that to subarachnoid hemorrhage as well, and other causes of communicating hydrocephalus. But by communicating, I mean obviously no obstruction intraventricularly. But what it does, what you're trying to do with it is you're trying to punch this thing through the inferior petrosal sinus into the cerebellopontine angle, and it opens up. It just drains in a one-way fashion, pressure gradient driven from the CSF space to the venous system. This requires patients to have a specific venous anatomy, meaning that you need there to be a nice curving angle of the inferior petrosal sinus as it's coming off the transverse sigmoid junction, because the jugular sigmoid junction, because otherwise you can't really advance it into a wall. It'll just kind of glide into the vessel along. The biggest pain with placing these things now is that they require a lot of support. So quadraaxial systems, like a lot of support, like a 12 French inside, like over a 10, over an 8, over a 6. And then, even then, what you're trying to do is you're basically trying to get a microcatheter into the intercavernous sinus, between the two cavernous sinuses through the inferior petrosal, to place an anchor. You can use it comes with its own anchor. This product comes with its own anchor and flat rail wire to kind of help pull everything up, but you can also just as effectively use a 640 solitaire. So you're basically going to put an anchor in the intercavernous sinus, and that's just to pull up the delivery catheter and be able to jam it into that angle where the inferior petrosal sinus kind of, goes away, goes down and curves. The scare that I think is valid in this is if you can't, if you really don't have that angle that's really, optimal to pushing the thing in, because you're really just kind of unsheathing a sharp point and blindly advancing it through the wall of the vein. If it just starts scraping along it, you can see how you get like a venous tear or something like that. But that's why patient selection, especially in these very, very early models, is extremely important. Here's a video.
And with worsening mental status over 2 years, as well as progressive,
and this is Kunal Rigor narrated,
gait instability, which was concerning for normal pressure hydrocephalus. She underwent lumbar drain trial with physical therapy evaluation, which demonstrated improvement in gait parameters. She was deemed a candidate for Ceravas e-shunt implant trial. Preoperative CT demonstrated ventriculomegaly. Seen here is a schematic of the relevant anatomy in panel A, a schematic of the planned intervention in panel B, a schematic of the e-shunt implant in panel C, and a photograph of the implant in panel D. The setup included an 8 French femoral vein sheath, multiple Cook shuttle guide catheters, a 6 French Envoy MPC catheter, a Phenom 27 microcatheter, an Aristotle 18 microwire, and the e-shunt implant. An 8 French femoral vein sheath was placed, and a weight-appropriate dose of heparin was administered to achieve a therapeutic ACT. An 0.35-inch exchange-length glide wire advantage was navigated through the sheath into the right internal jugular vein. The sheath was then exchanged out, and a 12 French Cook shuttle was advanced into the right internal jugular vein over a dilator. The Envoy MPC was used to navigate into the jugular bulb through the tower of support created by the telescoping 12 French, 8 French, and 6 French Cook shuttle guide catheters. A venogram was then performed, which elucidated the venous anatomy, including the inner cavernous sinus, the inferior petrosal sinus, and the internal jugular vein, as seen here in relation to an illustrative schematic. Next, the ipsilateral IPS was selected with the Phenom 27 microcatheter over an Aristotle 18 microwire, and the microcatheter was navigated along the intercavernous sinus just into the contralateral IPS. With the microcatheter at the junction of the intercavernous sinus and the contralateral IPS, the microwire was removed and the implant brought tip to tip with the microcatheter. The anchor was then unsheathed over a flat rail guide wire and deployed in the intercavernous sinus. Next, the delivery catheter was positioned at the optimal angle off of the flat rail guide wire in accordance with the natural curvature of the IPS. The change in the angle of the delivery catheter and the flat rail is seen here. The therapeutic anticoagulation was reversed with protamine. The 20-gauge needle was then advanced through the delivery catheter and pierced the wall of the IPS into the CPA cistern. Here you can see the needle and deployed anchor as compared to an illustrative schematic. A cone beam CT was then performed to confirm the location of the needle in the cerebellopontine angle cistern and to ensure no subarachnoid hemorrhage as seen on the panel on the right. The left panel demonstrates the position of the anchor in the inner cavernous sinus. At this point, the E-shunt implant was advanced through the delivery catheter into the CPA cistern. The implant is surrounded by an encapsulating shroud, which was then pulled back to release the proximal implant. The proximal radio-opaque marker within the red circle can be seen suddenly advancing forward, which represents complete deployment of the implant.
So
the anchor was then captured and with worsening.
I'll stop there, but you could see how, like, you know, this thing as it stands is kind of ridiculous. Like, you know, you're setting up these 4 giant catheters, you have to do all these spins, and then, you know, something that's also not mentioned in here is that even prior to doing this, you got to do a venogram spin venography, which, you know, because you really need to see everything, kind of takes a little while. And then the device itself takes like 2 to 3 hours to prep. You know, Dr. Rami was telling me that in Argentina they've gotten a little bit more swift at it, as you know, and that's an example, obviously, of optimization. The more you do something, the more you can kind of really limit how much you're using, how long it takes to do things, and find ways to make it, you know, faster, but equally, if not more effective. The next thing I want to talk about isn't so much a pathology, but just kind of an idea of a workflow. So, and that is the concept of, you know, using ambulatory surgical centers to treat patients with endovascular means who otherwise, you know, don't really need to be done in an inpatient setting. This both allows patients who are undergoing minor procedures like diagnostic angiography to have higher satisfaction rates, because these centers tend to move very quickly. You know, your turnover times end up being on the matter of minutes, versus, you know, half hour. They're there much less longer. They show up to get their procedure done, and then they're around for either their radial plans on or until their groin's good, and then they go home. And it can be safely done, as I'll kind of show from a preliminary series. And it also frees up a lot of space for inpatient you know, procedures in the hospital setting. It allows more bedroom. It allows things to move faster in cases that actually do need hospitalization. And you know, first this was done in my fellowship. You know, this was done in just diagnostics, and then was soon expanded to you know, chip shot flow diverters who would go home the same day. And when I was there, there was 5 flow diverters placed and a venous stent placed. All of which I was involved in. So this is just kind of talking about the system that Buffalo has set up, but and this is a paper that I published recently on the results of doing diagnostic angiograms. You know, we did a 100 or so, 96% of which I did, and it kind of started moving real fast, and patients were very happy with it. There's no complications. You know, it's also because they're cherry picking patients, you know, who are super healthy, and obviously, you know, we're talking about a very short amount of time. So, you know, as you more patients, like, you know, there's no procedure that's without complications. So statistically, someone at some point is going to have complication, but you know, it can be the acute management you can do for a lot of these things, that you have them available in these surgical centers with biplanar units. There's stroke thrombectomy gear. You know, you have the medications needed to recanalize or stabilize a patient, or, you know, do whatever you got to do. Place an EVD. You can even do a craniotomy on the spot if you had to, just to get them stable to transfer them to a hospital, you know, with transport. Thankfully, none of this has come up at all, you know, during the experiences so far, but you can speculate that with time, I mean, it will have to, and that doesn't mean that this is not valid. It's just, you know, that's realistic. Even if it's a 0.001% chance of a complication, then thousands and thousands of patients, one's going to have one. But that doesn't mean it's any different than doing it in an inpatient setting in a lot of these cases. And it's a huge, if you go into the, you know, the economics of it all, it's also a huge way to allow, you know, not that anything is done for you know, for making money, but it gives you sort of a mechanism of having a site that can be controlled by physicians, that can generate passive income, or at least partially controlled. Obviously, there's all those restrictions with that, but anyway, so these patients that we did in this center, very quick turnover times, very fast procedure times. When I'm saying procedure time, I mean the patient walks in the room, clock starts, and they literally do walk in the room, and the patient is wheeled out of the room, clock stops. So by procedure time, I mean total in-room time. And then turnover time is from the time the patient leaves the room to the time that the next patient comes in the room. The same teams who are, you know, serving as the circulators and techs are the ones who do the transport and do the turnover, and they move very, very rapidly because they're, I mean, partially incentivized to do so for a number of different means. One of them is that, you know, the sooner they're done, the sooner they go home. And patients are very, very satisfied with it. I mean, we just passed out a bunch of surveys and called them at 2 weeks after and so on, asked them to rate things from 5 and 5, and it was unanimously a 5 for my time that I was there. As I mentioned, you can do these also with flow diversion. And I'm sure that they're going to publish this soon, but about the flow diverters. But anyway, obviously these cases are done under conscious sedation, which makes it a little bit easier. You know, it has been demonstrated to be able to do things safely in conscious sedation, you know, multiple times. But, you know, in fellowship, they did everyone awake. You know, I think that there are certain patients that's, you know, a good idea for, and certain patients that maybe, you know, what's, you know, what are you kind of adding here aside from just making sure that anesthesia is not around, you know, so that you can move a little faster. I mean, you know, that can be solved with an anesthesia team that's dedicated to an angio suite and is, you know, incentivized to move quickly. I mean, at Tulane in residency, Dr. Dumont basically struck the, you know, the fear of God into the anesthesia teams. And so we were able to do general anesthesia, you know, 5 or 6 cases rapidly with a rapid turnover. In diagnostics, obviously they can be very easily done awake, and even simple flow diverters can be done awake with minimal patient discomfort. I mean, it's, you know, when you're dropping a pipe along an easy curve of a, you know, paraophthalmic or something like that in a big vessel with straightforward anatomy, patients do very well, and they're very satisfied with it. Things that are going to, you know, hurt more, like venous stents, or risk hypoperfusion or hypotension, like carotid stents, or things that are just in general more painful procedures, like MMA embolizations when you're putting DMSO, if you're using Onyx, or if you're doing any kind of embolization. You know, those remain more to discuss. And then obviously you have, you know, patient movement affects the ability of you to be able to see what you're doing and where you're going. And although you can become very adept at doing that with a, you know, a wildly thrashing patient who's having a stroke or needs an MMA embo, you can get really good at, you know, doing that. It's obviously it's much why, you know, you can just do it asleep. But for certain patients, this is a great avenue, I feel, and I feel like it's really a nice way to alleviate burdens on inpatient settings. I'm in the interest of time, I'm gonna just kind of skip.
Yeah. So Tyler, this was a fantastic talk. Unfortunately, we're at the top of the hour. The one thing is for sure is that the future is bright and it's limitless. So thank you very much for giving us this fantastic overview of what the future might look like for the next decade or so in endovascular and endovascular surgery. Thank you, everyone. Unfortunately, we don't have much time for questions, but thank you very much, everyone, for joining us, and we'll keep you posted for the next talks. Thank you.
Thank you.